Hi, I'm Dr. Brumfield. I'm the medical director, as you just introduced. I'm an internal medicine physician, and I take care of patients. I supervise residents taking care of patients, and I help supervise medical students taking care of patients. And I just want to say some of the most important work that I do for patients and their loved ones actually happens in the SIM Center rather than our direct patient care. And I think it's a very powerful experience to have learners come into our simulation center. I'm very fortunate and blessed to be able to work with such an awesome team. They really make this simulation center what it is. And I think we're kind of a hidden gem nationally. We do a lot of work here that is very innovative. We have all been mentored by a cardiothoracic surgeon that has expertise in team and collaborative care by the name of Dr. Paul Eulich, who's affiliated with us. And he's supports us still. And actually, Dr. Mary Kane is nationally known and actually just helped do our international presentation on some of the work that we're doing here in our Sim Center at our simulation conference. So we're excited to have you guys here. A couple of things that we just like to share right here at the beginning is a little bit of our vision of what we're after, maybe a little bit about our mission, and then we want to talk to you about something that's very important, which we call the basic assumption. And our vision for the work that we do here in the Sim Center is that we feel very strongly that we want learners to come here with curiosity and try to apply the knowledge that they are gaining even throughout their careers, but especially as students. And part of our work is we have two tenets before I move on to this. One is that we do all activities interprofessionally. We think it's important that we work with all of our colleagues, and we also work with patients and their loved ones in all of the simulations that we do. And we want this to be a safe place where people want to come learn, teach, and do research, and that's our vision. On this back wall is our mission, and I'm just going to read that to you, but you guys can read along. It's the KU School Medicine-Wichita Simulation Center is dedicated to the transformative education of healthcare professionals to improve safety, quality, and teamwork. And we're kind of this paradigm shift where improving teamwork is just important in improving the outcomes for patients and their loved ones. And we just feel like this is a great place to create that. One of the things when learners come to our Sim Center is we have to create a space where they feel safe to put themselves in situations that they feel vulnerable and observed, and also that we can dialogue about things that don't go well. Oftentimes, healthcare professionals are put into situations where they have 10% of the information and they have to make decisions because people really need that help in the moment if there are emergent situations. And so if you look over on this other wall, and I don't know if Kelsey can maybe get that in there, this is what we call our basic assumption. It says, we believe everyone participating is intelligent, well-trained, cares about doing their best, and wants to improve. When we try to eliminate every other assumption that we have and just hold that assumption about each other when we talk about the things that don't go as well as we want to, and so that we can find ways to improve healthcare and our teamwork and outcomes for patients and their loved ones. I would like to take you into our simulation center and introduce you to one of our patients and his wife. It's Kevin and Carolyn, and Erin Doyle is their nurse. So
my name is Erin, and I am a nurse by profession, and I have the privilege of being the program director of our fabulous simulation center. And this is our adult male mannequin. So today he is playing our patient scenario where his name is Kevin Rector, and this is his wife, Carol. Hi, Kevin. There's some people here watching us through the video.
Yeah, I heard that. It sounds great.
Okay.
Hello,
Is it all right if I tell them about some of your features and pull back your
you go right
covers?
ahead.
Okay. Kevin has quite a variety of things, as you may or may not be able to see. He is blinking his eyes. And then he has other features that we can assess when we're doing our encounter with him. So he has pulses that we can feel in his neck, which is the carotid. He also has them right down here for a femoral.
Careful now, it's chilly.
Yeah, sorry, and I'm just gonna be very careful with those covers,
Oh,
so,
I know, I'm just messing with you.
okay. So he has those strong central pulses, which are important in our assessment. He also has peripheral pulses, such as in his wrist, where they might take your pulse when you go to the doctor. And it's important that we check both sides. So he has a radial pulse in both arms. And then he has pulses in his feet, which are called pedal pulses. And that's an important assessment point, because if he had a blood clot or another issue in there, we might not have the same pressure, and we might need to move in a different direction with our treatment plan. One of the other great things about Kevin is that we can listen to him with our stethoscope. So he has heart sounds and lung sounds that our technician can change via the computer. And then Kevin can add to that by speaking through the microphone. So Kevin, is it okay if I pull your gown down just a little?
Sure, that's fine.
Okay.
While she's doing that, tell us who's here along with you, Kevin.
Well, it's my long suffering wife.
Well, hello, nice meeting you too.
I'm Carol, I'm Kevin's wife, and I do suffer long time sometimes.
Yeah, here we go.
So Kevin, as I listen to you, your heart sounds great. It's a regular rhythm, not skipping around, and your lungs sound very clear. So I'm glad you aren't having any cough, allergies, or beyond. Yeah. And then we have monitors that provide our vital signs information about our mannequins. So on this top row, we have our heart rate, which Kevin, your heart's beating a little fast at 115. It also puts the EKG rhythm strip so that we can see how the heart is working. It has this oxygen saturation level, or SpO2. We usually want that to be above 95% and make sure there's enough oxygen in the blood to get around and feed the heart and the brain and all the other places that love it. Down here we have his respiratory rate, how many times a minute he is breathing. And then over here in this left corner, we have blood pressure. This large monitor is just a mirror image of our touch screen. But if we wanted to update Kevin's blood pressure, there's a button here we can push. Kevin, it should give you a little squeeze on your arm. I'm gonna take your blood pressure again.
Okay.
And it will update our blood pressure for us. These are things that can be pre-programmed, or usually the way we do it is our technician adjusts them as the scenario progresses with our students based on the decisions they make and the actions they take or don't take. So Kevin, why are you here today? What brings you to us?
What happened?
Yeah.
Well, I was doing some spring cleanup, and I was up on the extension ladder and headed up against the house, and had gone up there, and with the hose, it was washing out my gutters, and I'm not sure what happened. They tell me I fell. It's like I blacked out.
Okay.
And I don't remember the fall or landing or anything like that. But I do know my left upper leg hurt. And they told me I broke my left upper leg.
Okay, so I think they're going to do some surgery on that to repair it early
That's what they
tomorrow
said.
morning. Yeah.
Yeah.
And you may not remember the blackout and the fall, but your wife Carol, she definitely remembers it. It was probably pretty frightening.
It was very scary. It was very scary. I didn't know that he was going to do that. He did it, even though we talked about not doing it. But anyway,
I'm
it
not
was.
dead yet.
I know. It's your lucky day.
Yeah, we're
It's
thankful
your
for
lucky
that.
day.
Yeah.
The other, go ahead.
It was a 10-foot fall at least, and fell on the sidewalk. And I called the EMT since he could not get up. I could not get him up. And
That hurt
so,
real bad.
I'm sorry, you did remember that?
Yes.
Oh, it
I
hurt.
remember the pain.
Oh, my. Yeah. So now I think I've given him some things and he's doing much better, pain wise.
Well, I'm very glad you didn't bump your head.
Yeah. Me too.
And we have some great orthopedic surgeons here on staff, and I know they will do a great job of fixing your leg tomorrow morning in the operating room.
I need to get back home and feed the cows.
Well, we're gonna keep you for a couple of days and make sure that everything goes well with that surgery. So I know that
The boys can do that, yeah.
you have boys that will
Yeah.
go take care of the cattle.
Yes, we do.
Because right now, we just need to make you the priority here.
It,
Well, I'm sorry, I got in the way.
it looks like we have some important information over on this whiteboard too. Oftentimes we use this for students. It looks like you're taking some medicines. Can you tell us a little bit about those?
Yeah, I take my Cinepro. They tell me that's for my blood pressure, I think. And they tell me I take pantoprazole. I've got what GERD or gastric reflux,
Okay,
where I get a lot of heartburn.
you do.
Yeah, and I take my Centrum Silver every day. What little hair I have, it's silver.
Well, I'm glad you're taking that. Now, do you, are you a smoker?
Yeah, I am.
Oh, I see.
I smoke about a pack a day. And most of my adult life,
Okay.
just can't quit.
Okay. Well, one of the things we can do for you, Kevin, because we absolutely can't let you smoke in the hospital.
Yeah, I know.
But I will look into if they haven't already ordered a nicotine patch for you. That will help in the couple days that you're here and having that physical withdrawal.
Oh, that would be great.
Oh, well, I didn't even know about them.
Hey,
Okay, so
I need some help over here. I think we got a baby coming.
Hello.
Hey, Victoria.
Hi.
Hey, hello. Well, here, I'm here to help you out here.
Oh, I need it.
You need it. Well, you're about to have a baby, I think.
Thank goodness.
Yeah,
It hurts.
you were three.
Yes, this is my wife,
Oh, cool. Number three?
Number 3. This is a
Okay.
boy.
And the last one.
And the last one, of course.
Yes.
Well, you're not quite. Are you starting to feel a little bit like you got a push?
Oh, gosh, I do.
You might just kind of pant just a little bit here for me, a little bit. You're not quite dilated all the way yet. So I think we're gonna, is this a boy or girl?
This is a
This is a boy.
This is a boy, we got it home.
We got
Finally.
2 girls.
2 girls. Ooh, okay. Oh, okay, if you gotta push, go ahead and start pushing.
Can't.
Can you push?
I don't know. Trying.
Uh-huh, what does
Okay.
it feel? I got a contraction.
Okay.
Push down, there down. Come on.
Okay. Okay.
Give it a push, push. You're doing superb, wonderful. Oh, hey, I can see your baby's head. There's no hair,
Oh,
but I can see your baby's head.
okay.
Oh, push. Oh, come on, almost got the head out.
Keep pushing,
Keep pushing, keep pushing. Big push. Nice big push. We'll have the head. Perfect. A little bit, now, okay, now I need another big push right now.
I'm trying.
Oh, you can do it. Come on, you can do it. You're almost there. You can do it.
Big.
Oh,
Oh, she
big
ran
one.
this little baby.
Keep pushing, honey.
Yeah, you're
We're almost there.
You're almost there.
Okay, come on.
Let's out.
Come
Get
on,
the
honey.
shoulders coming.
Okay.
Here we go. Almost.
Okay. Okay.
Whoa, hey, look at that.
Alright.
Yes, it is a boy. Oh, isn't he beautiful? He is. What's his name?
Gonna name him Hank.
Hank.
Oh,
Oh,
that is
Hank.
lovely.
Well, welcome to the world. To tell you what we're gonna do here, we're gonna first, before we're gonna put him right up here on mom.
Oh, my
And you have a
little
blanket
boy.
here we can cover him up.
We did it.
You did it.
Oh,
Good job.
He's beautiful.
Oh, you can touch it. Say
Look
welcome.
at Daddy.
Oh, Grandpa's gonna be so happy. We
That's
made
my
him.
baby boy.
Yeah. What do you think, Dad?
We've got a great son.
I think we do. He's wonderful.
Oh.
Cut the cord. Hey.
Thank you.
Good job, Mama.
Can you give me just another little push? We got your afterbirth. Come here.
Okay,
Here,
yeah.
It's out. It's out. You're all done. You're all done. Whew.
Great. Victoria, I see that Dr. Mary Kane is looking at your placenta because it's very important when you have a baby that we get the whole placenta out
Everything's there.
and it's all in one piece and it's very healthy.
Okay. Cord, everything looks great. Everything looks wonderful.
Thank you. You guys were
You did
Oh,
great.
good job, Mom. Good job, Dad.
Can't wait for the
I-
sisters.
I think my wife deserves all of it.
And how old did you say they were?
They're 3 and 4.
Oh my, are they excited?
They are very excited.
They're gonna be little mamas.
Oh, they will. They'll be great helpers for you.
So in about 10 years, he won't be quite as excited with those bossy sisters. They'll still enjoy it.
So I'm gonna talk to our audience just a little bit. Can you see the screen up here a little bit? You'll see also we have monitors right up here too. And what you see on the left side is actually mom, her heart rate, that's her EKG going along, and respiratory rate. What you'd see on the right side, and now that she's had the baby, you don't see anything on there, but what we would see on that right side of the top, we would see the baby's heart rate and somewhere between 120 to 160. And then at the bottom, you would see a line going along, would have little pills on it whenever she has a contraction. So we can, we actually speeded this labor up pretty fast, but we can make them go however long we want to make them go. And so we can use this to help students learn how to manage that baby as it's coming down and how to hold on to it. Babies are slippery and we just got to teach them all those things about what to do with baby. Victoria, we're gonna take a little change here. And we thought we'd just show you how we put the baby in this mannequin. Here's the mannequin. So we'll just do a little bit of mechanics here. Thought you might be interested. So if you don't want to watch, that's fine, but we thought you might be interested in seeing. And I'm gonna let Greg get this baby. Say hi. You want to put that baby back in so you can see how this mechanical baby actually works. And we haven't done it yet, but she has some different coverings that you can actually do like a cesarean section on for real. We want to do it with the baby. But we haven't been able to do that one just yet. But we're on that. But it's kind of interesting to see how this thing works. You wonder how in the world. So you actually connect baby here. Put him down in there. And Greg says baby's having a little trouble. You know, it's technology. So we always have to kind of fix things sometimes. And maybe we'll get it, maybe we won't. Not gonna cooperate. But you get the idea. The baby goes down in here and you can see him working with the computer over there, and you can set this. So we can have this baby come out in different ways if we wanted to. And we use a lot of lubricant around here on this baby. And I don't know if there's some questions or comments while we're here talking about baby. Are there any there, Sarah? Would invite you to ask some questions.
Hey, I don't see any in the chat, but I have a question. You mentioned having a different component to make it a cesarean section. Can you rotate the baby and deliver it as a breech, or is it just?
Yes, we can do that too. So we can
Okay.
do that, we can have him come up face up, So we could put them in those different kinds of positions that they might, the physicians and nurses have actually encountered.
Definitely. And does the robot have the capacity to have twins?
She does not. And I don't know, Kelsey, are they working on that, twins?
I haven't heard anything about the twins.
Yeah, we haven't heard about that yet. We do know there's one being worked on that we hope to get sometime. It's just much more flexible. The newer mannequins coming out are much more flexible than some of these that are still a little bit on the stiff side. Like her legs are not quite where I'd like to have them, but that's just the way she is. But no twins just yet. But you can see her nice pregnant belly that's up here.
Thank you, Dr. Kane.
Uh-huh.
If there's anyone else that has questions, feel free to put them in the chat and we can relay those on to Dr. Kane and her staff.
If not, we might roll around and let you see our control room. We thought that might be interesting to see where things happen, if we're ready to do that. Kelsey, do you want to take them back to there?
Sure.
We just kind of going through our sim lab.
This window you see here, from this view, it just looks like a mirror. We come back into the control room, where the magic happens. And this is Gary. So we can see on our monitor the bay. And then this is the other side of the window. We can see out into the lab. And when we turn the lights off, it's an even better view. So this is where we make it all happen. Oh, Aaron. Another one of our mannequins.
So this is Anne, and one of the things we love about her is she's one of the first mannequins that actually has movable joints. So when we met Kevin, he doesn't bend at the elbow, but Anne does. So part of that allows us to do a full musculoskeletal exam and make sure that all of her joints are moving as they should. It also allows her to cradle her baby. So she is a cousin to Victoria and Greg, and she's here to see the baby and gets to hold him.
No.
Great.
Yes.
And now I think we're going to go back to Kevin.
Hello, Kevin.
Kevin, you're just waiting to go to surgery, right?
He is. We're just in a waiting mode right now. Okay. So whenever they say he's ready to go, we're ready, right, Kevin?
Kevin? Kevin?
Wait a minute. Wait.
Oh,
Some help. I need some help. Somebody help me. Hey, we were just
calling
talking.
a code blue.
I don't know what's happening.
I'm Dr. Brookfield. I'm here to help.
Hi, Dr. Brownfield. Would you get the leads for the defibrillator hooked up?
You bet.
Hi, I'm Mary. How can I help you? Hi, Mary. Could you please get O2 or an ambo back? I will do that.
We were just talking.
Hi, Gary, can I help you?
Hi, Gary. Could you please hold
Yeah,
it?
take over the defibrillator.
Fantastic.
Yes,
Kelsey, yes. And can you get the pillow out so we can get the back of
I'll
it?
have you just wait right here. Perfect, Kevin, as you can, just
Thank
tell me
you.
here, maybe love them. and we're
Kevin,
gonna be working
Can I
on
get the
it
back
really
for
good.
me? Thank you. I'm right here. I'm not gonna leave you, okay? Yeah, you just keep talking to him. We're doing everything we can right
All
now.
right. I'm Dr. Brookfield. I'm running the code. I have a 67-year-old male that came in with a right hip fracture. He's with unconscious. It looks like he's
Kevin,
in
I'm right here.
Ventricular fibrillation. Anybody else notice anything else that's going on?
I did not notice anything prior to the
We're
Okay.
prepared to shop. Right here, impressions.
Does this have something to do
I've
with
got a
this?
good pulse.
Figure
Compressions.
that out.
Right, stop
Okay.
compressions. Pulse gone. Shoppable defect.
Clear,
Pulse
clear.
Clear.
All right, let's go ahead and put that backboard in.
Does this have something to do with this broken hip?
I don't think so, but we're gonna be looking at it. I'm worried that something else may have occurred. You keep talking to me.
Kevin, I'm right here. Can I drop any medications for you?
Yes, let's pull up one.
Kevin, you're doing
one
everything
amp
we
and
can.
get
1 amp of epi?
Yep.
Kevin, I'm right here. I'm not gonna
Good
leave you.
compressions, Chelsea. You get a little deeper.
Kevin. I have 1 amp of epi, Dr. Brumfield. Would you like me to administer it?
Please do.
Okay. Do you think I should call our children?
Let's just focus on Kevin right
Okay.
now.
1 milligram of epi in.
Excellent. All right, so we have a 67-year-old male has a history of hypertension, smoking. He had a blackout spell before he fell down, and broke his hip. He's now in ventricular fibrillation. Do we notice anything else that's going on?
I don't.
I
Kevin,
sus-
I'm right here.
I suspect he's had probably a heart attack. He could have had a pulmonary embolism. Anybody else notice anything else that we should be considering?
Carol, has he ever complained of any chest pain?
No, there is some heart disease in his family though.
Was that his folks or?
Yes, his dad. died.
Clear.
Clear. Thank you.
All right, let's go ahead and do the compression.
He's never been diagnosed with anything.
He hasn't, but it was his father that had. birth
Yes,
control?
yes, he died.
Why don't we go ahead and alert the heart cath lab,
I have
Dr.
it.
Shaheen, that we may have a patient?
I have organized rhythm, stop compressions. I have a good femoral pulse.
So he's,
Excellent.
Kevin,
Good.
Damn it.
so he's
All right,
breathing
let's go ahead
now?
and get a CBC, a CMP, let's get a
Breathing. I'm
troponin.
gonna just help you with a little bit of oxygen.
Okay,
Let me go ahead and give,
Kevin, I'm
325
right
milligrams of
here.
aspirin.
325
milligrams
milligrams
Try
of
to breathe on
aspirin.
That's correct.
Breathing.
Kevin, are you here with us?
Yeah, he said, what happened?
Oh, my
Oh,
goodness.
we thought we lost you, Kevin.
He's back.
Oh my God. Do that to me again, you scared me to death.
Hey, Kevin, I'm gonna go ahead and I'm gonna have a heart doctor look at him. I suspect he may have had a heart attack. We've got some labs that are coming. We may have to have that looked at, just right away, so we may have to go. do a
Okay.
heart cath.
Okay,
We've got Dr. Shaheen notified.
all right.
All right. We got him stable now, though, and we'll probably move to the ICU if they can't take him to the
And our
cath.
blood pressure is
Okay.
100.
Kevin, they're gonna take care of you.
Sinus
They're gonna
damage,
take
you know,
care of you, okay? They're gonna have some tests run.
All right.
Okay, okay.
Good job, team.
Yay!
One of the things when we are teaching our learners about doing adequate quality compressions in CPR is that the tablet that operates Kevin, the mannequin, also has some feedback device. So it's very important when we're doing compressions that they're good quality. They need to be deep enough at the correct speed. And our tablet shows us that feedback. And I think Jeannie, oh, here comes Greg with that tablet. So I'm gonna do compressions and Dr. Brumfield, you can talk and hear what's showing on the screen.
Good. So right here, we, this spot, we can see if she's going deep enough. This top and this bottom box should both turn green. And that means that she's doing them deep enough and letting off the chest. So when she's squeezing the heart, that's pumping the blood. And so we have to squeeze the blood out and then let the blood back in. This over here is how fast she's going, and it should be in the green zone. We should be doing about 100 compressions per minute to make sure that we're doing it adequate. And so long as that's in the green zone, we're doing pretty good. To do really good compressions, we have to change out the people all the time because it can be very fatiguing. But this is a good way that people can see if they're doing it a good job. The responsibility of the person that's not doing compressions, that's going to do them when the one that's doing them finishes, is to coach them to make sure that they're doing good compressions. So that's probably getting heavy, Greg. All right, thank you, Gary. We're wearing everybody out, I think. So it's a really nice tool that gives students feedback on their performance, and they can take that with them when they leave, and they actually have to do compressions in real life.
We have a variety of other equipment here that we haven't set up for you today, but we refer to them as task trainers. And so they're usually a mannequin that's just part of a body. And so we have some that are partial arms that we can wear, and that allows our students to learn how to draw blood and start an IV. We have other task trainers that allow for sensitive exams, that allow for Foley catheter placement. And we even have a task trainer that the students get to perform a lumbar puncture on to determine if the patient has meningitis.
Oftentimes you'll have heard that as a spinal tap.
And so we are just really excited that our students and residents get to practice on our friends and our task trainers before they practice on us in the real world. And it has just been fabulous working here and watching it grow, and the students seeking out new opportunities to learn new skills.
Erin, we had a question from Maria in the chat. She was wondering if you had any pediatric patients.
We do, and I think Kelsey is going to pan to the right. And we have Junior. So Junior is our child mannequin. He is one of the earlier models, so his arms also do not bend like Anne's, but the newest ones that are coming out are doing that. And when he's charged up and programmed, we can listen to his heart and lung sounds. We can hook him up to a monitor so that we have all of the active vital signs displayed. And our students in our pediatric clerkship really enjoy working with it because they have the opportunity to design a patient case during that event. And they are tougher on each other than we could ever be. But they really do some exciting things, and it's just great learning to watch them think through and what is involved in caring for that patient and diagnosing it correctly.
Fascinating. Thank you, Erin.
I'd like to speak to the end of this is Mary Kane Cropping. And COVID has put a kink in some of the things we do here, but we really like to work interprofessionally. Now, we do have a whole scenario with the clinic setting that we're doing for Zoom, but we are looking forward to getting back to doing it in person, where we'd actually work with students who are from various professions, especially over at Wichita State. We partner with them, and we have students over there from audiology, dental hygiene, physical therapy, PAs, have all been over here, as well as social work students from Newman. And we are just so pleased to have all of them come over and learn. And here in the building, we also have pharmacy students, and as long as our medical students. So sometimes we have scenarios where we will have several of those professions together. Our goal being is they learn to talk, communicate with patient and family all at the same time.
The shot, the final shot. Should be all of us, right?
Yeah. And I'm going to get our team all to come up here.
And as we're assembling, Carol, can I ask you what your experiences have been being a standardized patient and getting to play a family member?
Sure. I have been a standardized patient since 2013, so for several years now, and I play many different parts. It depends on what they need in the standardized patient center. But we play the part of a person that has certain symptoms, and we memorize what our symptoms are and our medications and all of the things associated like a person with a real illness would. And then the students come into the room and they examine us, and then they go out and create a note about what was done and what they think ought to happen. And then I assume they meet further with their instructors, of course, but if you're a standardized patient, you don't see that part of it as much, but it's an awesome job, and it's a lot of fun, and we take it very seriously. I love it.
And we are very fortunate because we get to share the standardized patients to play the family members in many of our cases. Because as Dr. Brumfield shared in the beginning, we believe that the patient is part of the care and their loved one. So we want to have those roles represented in each case we do.
I just want to comment too about Kevin. There's a lot of things we can do with Kevin that we haven't showed you and we won't be able to show you today, but we do this thing called moulage, and Kelsey, our technician, is wonderful at it, but we can make him have wounds, various kinds of makeup and what have you. So he's had a variety of things gone on with him before, and we just can make as much of those possible as we try. Our goal is to be as realistic as we can. We tell our students that, yes, this is a simulation lab, but we want the scenes to be as real as possible. And we actually have this thing called a fictional contract that we set up with them. What it is, it's like, yep, this is in a simulation lab, but if you will put yourself into it, we put a lot of work into trying to make the scenario real. And so put yourself into it, and you will learn so much more. And the students do. It's beautiful just to watch them work as just as a piece person, which we consider him. He's our dearly beloved Kevin most of the time. So we would welcome questions for anyone here on our team. We'll answer them the best we can. What else would you like to know?
But we want to invite Kelsey and Greg to come down to be in the shop so you can see all of us.
Okay, it looks like we have one question. It says, can you switch out his parts to simulate wounds?
Wound?
Kelsey, you wanna
Wounds.
take that answer?
Switch out.
They're asking if we can switch out parts to demonstrate wounds.
Right.
Yes, it depends on the mannequin as to if there's parts like you actually exchange. There's some really awesome like trauma mannequins. We don't have one, but you can like take off the whole leg and put a severely wounded leg on. With him, mostly our moulage are like attachments that we put on him.
But we have one that can make him a very large obese patient.
We do, yes.
And we have a case that we make them very large so that they have an experience with a patient that is obese and has complications due to that.
When you were asking that question about switching out parts, I thought maybe you were going with male, female, and yes, we can change out those parts. So Kevin can become a she. We have wigs that we put on her and make her a her. We have a variety of those, so that's kind of helpful too. We keep some extra clothes around that we, maybe they just brought in from an accident, so they still have some clothes on. So we try the best we can to make it as real as possible.
Yeah, I got a little clarity from the question, and the person was asking with arms and legs, is that something that you can switch out on Kevin?
Not on him. Victoria does have one you can switch out and make her have like a DVT, a blood clot in her legs, or her legs all swollen. You can switch and put that leg on. But Kevin doesn't have any arms or legs. You can switch in and out.
Gotcha.
But we do have a sleeve, which I think is really interesting, has tattoos on it.
Yeah, we have lots of tattoos.
Lots of tattoos, so we try to, just make a variety of scenarios and make them different people along the way. It adds to the interest and just, I don't know, keep things going better.
Do you use these types of robots for suturing at all, or sewing up any kind of thing, or does the material itself not lend to that and it's more internal?
That one.
Okay, so the mannequins don't lend themselves well to suturing, but we have several different types of task trainers
that our boards, the ones that we are currently using, have a variety of different angles and cuts, and some are jagged and some are straight. And then the students get to practice suturing those. And right now we're working with several of the surgery clerkships as well as dermatology. And the students come and check those out a week before they're going to do that rotation. So they have some practice tying those knots and using the equipment. So when they get to that time with the surgeon and physicians there, they don't have to spend time learning those basics. They're just ready to go.
That's so fascinating.
Here's one of our suture boards.
Okay, yeah. We've got another question from the chat. Does his mouth stay open the whole time, or does, I see his eyes are closing, open and closing. Does his mouth?
Unfortunately, yes.
Let's see if I can get closer.
Yeah, we just call it a mouth breather. Yes, unfortunately it does. And kind of tilt his head up just a little bit here. We can see it. I will tell you that if he can become cyanotic, or meaning he's not getting the oxygen that he needs, and what happens then, there will be a little blue light. And I think Greg actually went back to probably turn that on, and we might be able to see it here. So just to give an indicator of that he's got blue lips, the idea is that he's turning blue on us. And I don't know if we'll
His
get there or
chest
not.
is also rising. I don't know if you can see.
Yeah, I don't know if you can actually see this, but his chest is, actually does move up and down. I'll put my hand on it. Maybe that'll be helpful, but. And if you're here, you could hear him breathing. We could make him have wheezes, different kinds of sounds from the lungs.
And one of the reasons his mouth stays open all the time is to allow for the learning opportunity of intubation. And so we can actually intubate him, put him on a ventilator, and maintain the airway support that way.
And you saw that during that code blue that we were doing, we stood back so that he could be shocked. He is actually shocked.
Oh,
Yeah, it is a live defibrillator. And yeah, so we make very clear to students stand back. So when we say be clear, all clear, we mean it. Yes, Kevin can cough, and Kevin can do various kinds of things if we want to make him do that.
how many robots does KU Med have in your facility for this type of education?
Erin?
So you have met most of our mannequins. So we have Kevin, the adult male, which can also be swapped out to be an adult female. We showed you Junior briefly. Victoria is our birthing mom. And then we can switch with the newborn to a separate baby mannequin, which is a high fidelity. And if we wanted to do a scenario on a newborn with complications or distress, they have the capabilities to start IVs, to actually do a code blue, as well as to intubate the infant if needed. And then we have Anne. And other than that, the rest are task trainers, which are parts and pieces.
Right. Thank you. Well, any more questions for us? You can go ahead and put them in the chat, and we'll send them along. If we don't have any more questions, we'll go ahead and conclude this recording. I just wanted to say thank you for participating.
Here in the Sim Center. It takes all of us to make this happen. And so it's just a privilege to get to work with all of these people.